small topic છે એટલે બધી વાત નહીં લાગે 5 to 10 minutes.
તમારા માટે સ્મોલ, અમારા માટે
તમારા માટે smaller.
ના ના.
So I will be talking about frozen shoulder, which is adhesive capsulitis. This was recently from new guidelines. This word has been now eliminated. Now they say that frozen shoulder is not an adhesive capsulitis because there are no real adhesions in frozen shoulder. There is only chronic inflammation, proliferative inflammation. There is no adhesions. So it is a chronic inflammatory fibrous disorder, most debated and most ill understood pathology of the shoulder, and there are no real adhesions, so it has been now eliminated. This now epidemiology, the prevalence is in general population is 2 to 5%. It affects more men and it affects mostly on non-dominant men. Mostly peak incidence is between 40 to 60 years. 20% of the patients develop similar symptoms on the opposite side. Bilateral simultaneous presentation is observed in 14% of patients. It has a lot of associations with diabetes, hypertension, stroke. There is a common pathology which also occurs after ischemic heart disease and stroke is shoulder hand syndrome, where it is a reflex dystrophy, similar presentation, stiffness, pain, hypersensitivity, might have some radicular symptoms. We might consider these patients as having frozen shoulder. Treat in the guidelines of frozen shoulder like physiotherapy, NSAIDs, but patient might not respond. So that is one common differential diagnosis.
Now, I will go by the percentage of 100 patients of frozen adhesive capsulitis. The association, diabetes 50% association. What kind of percentage?
40% association.
And
it
what
also
other
depends
disease?
on HbA1c. HbA1c. So
40%.
if the patient is having uncontrolled diabetes or if patient is having long duration diabetes, there are more incidences of frozen shoulder. Similar with hypothyroidism, similar incidences, around 30 to 40% incidences. But it is not the only thing that can cause frozen shoulder. Even in the primary, where there is no trauma before or there is no any incidence of infection in the shoulder, still there are 60% of patients who will not have diabetes or hypertension, still they will have frozen shoulder. So it is closely associated but not the only cause.
The single most predisposing factor for frozen shoulder?
As in maybe diabetes.
It's immobilization.
Immobilization is there, yeah, that is also true, but that can be considered, but that is again whenever there is an immobilization, it could be shoulder hand syndrome also.
Yeah, but so both goes in the same spectrum. Predisposing factor is the same.
So for the treatment purpose, we divide the frozen shoulder into 3 stages, clinico-pathological stages: freezing stage, frozen stage, thawing stage. Initially it used to be considered that freezing stage is only for 1 month, but now the newer studies, the latest evidence from where I have taken this, they say the freezing stage can persist up to 12 months, 4 to 12 months. Then there is a frozen state. In the freezing state there is more pain, less stiffness. Patient will have referred pain over elbow or over neck. In the frozen state, patient will have more stiffness and less pain. In thawing state, both the symptoms will gradually decrease. But whatever residual stiffness patient might persist after frozen state may continue if patient is not being mobilized well in frozen stage. So now they say this. Initially it is a self-limiting condition, but initially it used to be considered that it takes 1 year to completely for complete resolution. Now they say it can take up to 24 to 26 months for complete resolution of frozen shoulder, with or without any residual stiffness. So the common
if you go by the previous slide of freezing, there are symptoms so is
freezing is a pain. First is more
in particular movement.
I will come to that. Pain over deltoid region. Deltoid region. Patient might can go referred to elbow or can go up to paraspinal upper back region. Then the other thing is the first movement which goes in frozen shoulder is internal rotation. So how do you check internal rotation? Is this. This is internal. The patient will typically tell that he will not be able to comb hair or it is difficulty in wearing clothes. The second movement which goes is external rotation. So patient will not be able to throw something or will have a lot of power while throwing or picking up something. The third movement which goes is abduction. So patient will not be able to lift the shoulder, but by the stage patient reaches the abduction stage, he is already in the frozen stage, not in the freezing stage. And the fourth is forward flexion. So whenever there is an involvement of the forward flexion, that means patient now has a global restriction of movements. So that is the maximum involvement of the frozen shoulder. There are a lot of other criteria, and as in if the movement of external rotation is less than 10 degree, or if the patient is not able to do forward flexion more than 100, less than 100 degrees patient able to do, then it is called global restriction. In such cases, then there is a high possibility that patient might persist some residual stiffness at the end of the resolution of the frozen shoulder.
So during freezing state, only pain will be
only pain will be there, and our focus should be even on the physiotherapy to do pain relieving physiotherapy and not focus on lot of exercise. If you do that, that will increase the inflammation, that will increase the pain, and patient will not comply with it. So first initial phase, patient typically, my personal observation is patient typically presents after 4 weeks. The routinely present between 3 to 5 weeks whenever there is a frozen shoulder with pain, because it gradually increases, and by the time patient is coming, he will have internal stiffness of the internal rotation, but still with some pain he will be able to do it. If you follow that patient for 1 more month, then that will be gone. But if we start pain relieving physiotherapy, and if patient keeps on doing the routine work, because the most common problem with frozen shoulder is if you have pain, you tend to reduce your mobility. That is what sir said, that if there is an immobilization in any stage of frozen shoulder, it will give more stiffness. That is the main
point is
first movement which is being affected is internal rotation.
Yes.
I guess when last time we discussed the frozen shoulder, you told that first movement was external.
External, yes. But this has been, as in,
This is an update.
I've been coming up with some updates in the last 6 months.
You should also give history here because आता मला याद आ रही है everybody might have.
I know, even I used to feel the same till last
Yeah.
time, but the newer study says the first is internal rotation.
So any upcoming points which are new, highlighting this is new or previously it is this.
my point is when the freezing pain is something, sometimes you cannot differentiate between C5 radicular pain because no signs are there.
Yeah,
But
but
it is only pain.
it is only pain, but mostly if it is coming from the neck or if it is related to radiculopathy, patient might give some numbness or tingling symptoms, or the most common symptom is you check the active and passive movements. If patient is having pain in passive, as in if we are doing the shoulder examination and patient is doing by himself, if patient is having a radicular pain and when we are doing the shoulder passive movements, patient will not have any pain. Patient will allow you to do passive movement till it is possible, but active movement will be painful. But when there is a frozen shoulder and if it is not gone into frozen state, till then patient will not even allow you the passive movements, because any inflammation, because of the chronic inflammation, any movement will be painful.
So pain relieving physiotherapy is a sort of milder stretching. That is what you want to make by that.
Short wave diathermy
Okay.
or extracorporeal shock wave treatment or whatever local application. Even sometimes some massage can help, but not range of motion exercise or strengthening exercise. Sorry sir?
And you are allowed to do the routine activity.
Yes, routine activity is allowed in every stage. You don't have to immobilize, you don't have to give shoulder arm pause. It will increase the pain. So the common risk factors are ischemic heart disease, previous trauma, stroke, shoulder hand syndrome. Even shoulder hand syndrome might eventually lead to frozen shoulder, but it might start as shoulder hand syndrome. That is aware through
That depends on who
if
presents.
it is frozen shoulder, and thyroid as a first cause.
So who presents also matters. આપણે કે તમે પ્રેઝન્ટ કરતા તો આપણે ડાયાબિટીસ ઉપર લખત.
મારા મને ટ્રોમા વગર.
Yes.
So diagnosis, it is mainly a clinical diagnosis. Recently USA has helped. It shows the increased thickening of the coracohumeral ligament and increased vascularity of the rotator interval. Rotator interval is the space between the rotator cuff muscles. We have to do X-ray to rule out the other causes like calcific tendinitis, AC joint arthritis, and cuff arthropathy. This AC joint arthritis with frozen shoulder is a common association, where because of the acromioclavicular bursitis, because of the AC joint arthritis, and there is in arthritis there is a new bone formation like in any other arthritis of the body. So here the space is very less. It is less than 2 mm space. So whenever there is a new bone formation or bony spot, and in such cases if we go for aggressive physiotherapy, it can lead to rotator cuff tear because there is a friction between this new bone formation. That is why X-ray is very important before starting physiotherapy. If there is any signs of AC joint arthritis, we should not go for abduction exercise because eventually patient might come back to you with rotator cuff tear. Yesterday only I operated one case of rotator cuff tear. 1 month back, patient had been diagnosed with frozen shoulder without X-ray. Patient also had AC joint arthritis with hook type of acromioclavicular. So because of that, patient started physiotherapy, and suddenly patient without any history of trauma presented with inability to lift shoulder, and there was all because patient was on eco-sprint, patient had all the signs of some muscle tear or something, and all redness was there. So when I got an MRI, I saw complete rotator cuff tear. So that happened because of the arthritis. So first part, as in every presentation, I always start with patient education. So first, patient need to understand that it might take up to 2 years to completely resolve, and also it is a self-limiting problem because the more patient will get pain, more stiffness will get, patient ફરતા થઈ જાય પછી ચારે બાજુ કે આને કરું શું, અને એમાં the most common place where they will go is a physiotherapist. And if physiotherapist is not giving, as in the patient, whenever there is a loss of movements, and when the patient is a frozen stage and the patient movement નથી આવતી, physiotherapists tend to take it as a challenge. A movement ના તો છે નહીં આવે, and in taking that passage they do rotator cuff tears, they increase the chances of cuff arthropathy and all the other complications. So if the patient is well educated, it is easier for us to get a good comfort.
So what is self-limiting? Symptoms or pathology?
Both. After 2 years, it can have some residual stiffness at the end of 2 years or maybe 1 year. It is not in all the cases that it will resolve in 2 years. It might resolve in 1 year also. So we say 1 to 2 years. But both the things are self-limiting. Even
So in an ideal case, your inflammation will go away.
Yes. It will go.
Or there is all fibrous tissue now.
Not all fibrous tissue, only anterior capsule will have. This is basically involvement of the only anterior capsule and all the ligaments which are anteriorly to the anteroinferior region of the shoulder region.
So once that region becomes fibrous, that ligaments become fibrous, your pain is gone. That is what you want to say by self-limiting.
Pain will go, but if patient has not been mobilized well during that 1 year or 2 years, then it could lead to residual stiffness.
Yeah, but self-limiting, is it a correct word here?
Yeah, it is a self-limiting.
Pathology is self-limiting.
Pathology is self-limiting. Even if you don't do anything, the patient accept it. Don't go to any doctor. Don't go to any
So you have to
physiotherapist.
say end result is there, which is stiff, fibrosis, and then everything goes. That is what.
There are many patients who recover from, as in without meeting any doctor.
But in that case, there has to be some restriction of movement.
There will be some restrictions.
Self-limiting word will say કે તમે જેવા હતા એવા પાછા normal થઈ જશો.
No, the pathology is self-limiting, but there is a terms and condition that with or without residual stiffness.
Little misguiding here. Self-limiting means that your everything has become in a remission phase or cured phase.
Only pain will go.
Only symptom goes. Pathology तो यार पूरे भूखा बोलाए પછી જવાની. It is not self-limiting. MI if I dead થઈ ગયું now MI self limiting, there is no MI now. So it's not like that, no?
એટલે પેઇન જતું રહ્યું ને
The symptom, that is why I asked. Symptom is self
But
limiting
even
pathology.
જે અંદર પેથોલોજી ચાલી રહી છે એ પણ જતી રહેશે પછી there will be no
પણ દોસ્ત ત્યાં એને જગ્યા નથી હવે જેટલું ફાઇબર્સ કરવાનું તો એ કરી નાખ્યું. Matter ends there.
not the whole capsule ને આખું capsule જાય if it leads to the further disease like cuff arthropathy or if it leads to shoulder arthritis then I would say it is not self-limiting.
So how many percentage of cases those complications occur?
It does not occur. That
In
is
any cases?
because of frozen shoulder eventual result cannot be shoulder arthritis. It can only lead to residual stiffness if not mobilized well.
Exactly. So that is the whole point. So pathology still the residual stiffness is a pathology. It is not a non-physiological thing.
Yeah, you can say
Right?
You can say, but it's like
Okay, sir, I'm a time waster, sir, but you got my point. I
yeah,
got your point.
whatever you were saying that even stiffness is a problem. You
So,
said it's already residual
suppose we
stiffness.
are talking about rheumatoid arthritis. So there are remission and recurrence occur. So in remission phase, you are absolutely inflammation less. There is no stiffness, nothing, no
But it will
inflammation.
recur also, no?
Yeah, it's very recurrent. Yeah, so that is in some of the things you might get it is self-limiting. So self-limiting, there is no pathology, there is no residual thing.
Okay.
That is called
Okay,
self-limiting.
so I think yeah, we have to reframe the word
Yes,
self-limiting.
exactly. That is the
So in the freezing stage, NSAIDs, oral steroids, I don't personally use, intra-articular steroids and pain relieving physiotherapy. So the maximum benefit of intra-articular steroids.
How
is-
oral steroid will work here?
Yeah, many orthopedic surgeons give the recommended duration of giving oral
But
steroids.
this capsule is supplied by blood supply.
Yeah, it is very rich in blood.
Okay.
I'll show you one photo.
ઓવરઓલ સ્ટેરોઇડ કેટલું ને ક્યાં સુધી
The recommendation says 6 weeks. So that is what. For oral steroids for 6 weeks. Intra-articular steroids, it gives good relief. So patient tend to take it come back for multiple injections, but it is only recommended only once during the whole course of frozen shoulder. And NSAIDs, the evidence says to give for 6 to 8 weeks a good dose of NSAIDs reduces and smoothens the process of freezing stage. So patient will comply more, and if physicians allow to give NSAIDs for 6 to 8 weeks, that is the only concern. Otherwise, it gives good results and it gives good compliance.
It is risky, but it is a
more than 50% of patients who receive NSAID, they develop excessive symptoms. At present, the scenario, even young person can body leg pain bare.
ફિઝિશિયન
That was not the previous case, but અત્યારે તો 50% લોકો
ફિઝિશિયનની જરૂર બી ના પડે કેમિસ્ટ મસ્તી થઈ જતા
બધા કેમિસ્ટ भी ના મળે કિડની બગડ છે
કિડની બગડ છે એવું કરીને અમારે એબ્સેન્ટી આપે આવા અમે બે ત્રણ જોયા કે કેમિસ્ટ જ કીધું છે આનાથી કિડની નહીં બગડે. So when we come to frozen state, because it is the most problematic state because patient will also have pain, patient will also have a lot of stiffness, and patient is already tired of this thing because it has already been 3 to 4 months. So in such cases, there are a lot of options. One is mobilization physiotherapy, hydrodilation. It is done in the local anesthesia where normal saline is injected into the joint of 1450 mm. The joint capacity is routinely 15 to 20 mm. We inject 3 times to that, and then it increases and basically increases the cavity of the shoulder joint and eventually relaxes the capsule. Calcitonin supplements has a good role in frozen shoulder. It has a systemic inflammatory response which will have a lot of anti-inflammatory effect on the capsule and can give good pain relief and allow good mobilization. Shockwave therapy, and in resistant and less than 1% cases, our anesthetist friend can also give suprascapular knock-down. In the thawing phase, when we feel that patient might continue with having lot of residual stiffness, in such cases, my role comes as an arthroscopic surgeon, where I would do arthroscopic capsular release. This is a picture of frozen shoulder, with lot of this whole tissue is inflammation. So because of inflammation, there is stiffness. So if you clear all this inflammation, if you put a hole in this is a rotator, this is biceps tendon, this is supraspinatus. So in between, if you put a hole and increase and try to reduce this all the fibrous tissue or inflammatory tissue, it will increase range of motion post-operatively. So I will first cancel the first statement, which is self-limiting. Better control of diabetes and hypothyroid gives less stiffness. We have to identify patient into correct clinico-pathological stage of the disease. Start physiotherapy early according to the stage of the disease. Consider manipulation under anesthesia, hydrodilation,